So today we're going to be talking about the Wilbrand's knee, and it's called the knee because it was thought to be an anatomic bend in the nasal fibers as they're crossing. So as you know, in the chiasm, the nasal fiber crosses. The nasal fiber is the temporal field, and the temporal fiber is the nasal field. And so when you have a chiasmal lesion, it hits both nasal fibers, which produces a bitemporal heminopic field defect. However, because the nasal fiber, as it's getting closer and closer to the chiasm, is trying to cross, and the temporal fiber is trying not to cross, that can cause a dissociation between the nasal and the temporal fiber at the junction of the optic nerve and chiasm. And so the Wilbrand's knee was supposedly this bending into the contralateral optic nerve, a knee of inferior nasal fiber going into the contralateral nerve. And so if you had a lesion right at the junction of the optic nerve and chiasm, you would not only, if this was right eye and this is left eye, you would not only get an optic neuropathy in the right eye, you would get a superiotemporal field defect from the inferior nasal knee of Wilbrand, and that thing was called a junctional scotoma. Now, it turns out that Jonathan Horton has done some excellent work showing that this thing that Wilbrand found, this knee, was created by enucleating this eye. So it's an artifact of that enucleation pulling the fibers up. So he repeated the experiment without doing the enucleated eye, and there was no knee. However, it doesn't matter whether this knee exists or not anatomically, because the localizing finding, this junctional scotoma, is the same whether you put the lesion there or you put the lesion there. It still localizes to the junction of the optic nerve and chiasm, regardless of whether that Wilbrand's knee exists anatomically or not. So it is really just a semantic and academic debate whether the Wilbrand's knee exists or not anatomically, because its localizing value to the junction of the optic nerve and chiasm remains clinically and radiographically relevant. And for a clinician, what that means is if you've got this kind of field defect, a junctional scotoma, you really have to image that patient because that is a compressive lesion at the junction of the optic nerve and chiasm, regardless of whether the Wilbrand's knee exists or not. And the most common causes, pituitary adenoma, meningioma, and craniopharyngioma. So you need to know about Wilbrand's knee, even if it doesn't exist.